We hear a lot about depression in the news these days, and it seems like rates of depression are going up and up. So how can people be helped? What treatments are being used to help sufferers of depression? Hey everyone, welcome back to Bear It in Mind. On this channel we explore the world of psychology so that we can better understand ourselves and others. In this video we're going to explore the way that cognitive psychology approaches treatments for depression. This builds on the previous video on the cognitive explanations for depression, so give that a watch first if you haven't seen it yet. The main cognitive treatment we're going to focus on is called CBT, which stands for Cognitive Behavioural Therapy. The NHS in England defines cognitive behavioural therapy as a talking therapy that can help you manage your problems by changing the way you think and feel. You may remember from the previous video that the cognitive explanations of depression place the focus on the irrational thoughts that sufferers with depression have. As a result, the treatments focus their efforts on challenging and changing these irrational thoughts. Building on the theories of Aaron Beck and Albert Ellis from the previous video, the aim of CBT is to try to change the negative patterns, the negative schemas people have, and to change the irrational thoughts people have. CBT is only interested in your present problems and does not explore any issues relating to your past. It's trying to change the irrational thoughts and the behaviour that naturally flows from your thoughts. So firstly, in terms of Aaron Beck and cognitive behavioural therapy, his treatment builds on his negative triad theory, which looked at how people suffering with depression can have 1. Negative self-schemas, 2. Cognitive biases, and 3. The negative triad. As a result, Beck's cognitive therapy involves the following. Thought catching. This is where the patient identifies their irrational thoughts and their negative triad, their negative view of themselves, their negative view of the world, and their negative view of the future. This can be done by keeping a thought diary. Patient as scientist. The patient generates hypotheses to test how accurate their irrational thoughts are. Did what they think would happen actually happen? Evidence is presented for and against their different irrational thoughts. Behavioural activation. Patients are set specific tasks to help change their behaviour. Now, secondly, in terms of Albert Ellis, his version of CBT is known as REBT, standing for Rational Emotive Behaviour Therapy. Ellis's ABC model to explain depression, covered in the previous video, stated that there is an A, activating event. This is simply the event that occurs in someone's life. B, beliefs. Here the focus is on the beliefs or the type of thoughts that a person has about the event. How are they interpreting the event that has happened? And C, consequences. This relates to the negative feelings and behaviours that result from the negative beliefs. For example, let's pick the activating event or failing your driving test. People may have beliefs, and they may believe certain ideas or assumptions must be true in order for an individual to be happy. They may say things like they're never going to pass their driving test and they must pass their driving test if they're going to be an adult, if they're going to be successful in life. Or they may say, I will be a fully functioning adult if I can drive. And the C, consequences of them failing their driving test or simply having challenges and difficulties whilst practicing driving can lead to anxiety, a lowered mood, and depression, with the potential outcome of perhaps giving up driving altogether and having a negative view of themselves. Now, in order to develop this ABC model to treat depression, Ellis proposed D and E. D standing for disputing. Ellis referred to it as DIBS, disputing irrational beliefs. Examples of disputing include logical disputing. The therapist questions whether this way of thinking makes sense. Is it rational? Empirical disputing. Is there any evidence? The therapist may ask what evidence exists to show that their belief is false. What evidence exists to show that their belief is true? This disputes irrational beliefs through showing they are not consistent with reality and there's no evidence for them. Pragmatic disputing. Is this belief helpful? The therapist asks how practical and helpful believing those thoughts actually are. Let's apply this disputing of irrational thoughts to our earlier example of driving. Yes, you failed your driving test. But is it common for people to fail their driving test a few times? Have you been successfully driving on your practice lessons? What things did you do well and successfully on your driving test? Is it going to help you in your future driving tests if you think that you're never going to pass? This then leads to E effects. The effect then of disputing these irrational thoughts is to help the person to be more rational in their thinking about the situation and to change the way they feel about it. Now, CBT sessions with a therapist can last anywhere between 5 and 20 sessions, and so requires quite a lot of commitment from the person. Furthermore, homework. Wait, hold on a minute. Isn't this meant to help me treat depression? Why are we talking about homework? No, not that kind of homework. For both Ellis's REBT treatment and Beck's CBT treatment, the patient set homework tasks. It's important after the session for the patient to practice identifying their irrational thoughts and to challenge them in everyday life. This can then lead to change in behaviour. For example, a patient who suffers from anxiety in relation to driving may be set the assignment to arrange to meet up with a friend in a location that requires them to travel a short distance by car. As part of this process, they would identify the irrational thoughts they may have. For example, worrying about whether they would stall the car, or fears of where to park, or what people who are watching them drive might be thinking. They would then counter these irrational thoughts with what they have learned from their CBT sessions. Let's discuss the cognitive treatments for depression. Supporting evidence for the use of CBT in treating depression comes from March et al. In 2007. They studied 327 patients aged between 12 and 17 years old. They were all diagnosed with major depressive disorder and they received either cognitive behaviour therapy, drug treatment with fluoxetine, which was part of a placebo double-blind trial, or a combination of CBT and the drug. What they found was that the rates of depression improvement after week 12 were CBT 48%, drugs 62%, and combined 73%. The rates of depression improvement after week 24 were CBT 65%, drugs 69%, and combined 85%. And finally, the rates of depression improvement after week 36 were CBT 86%, drugs 81%, and combined 81%. This study shows the positive impact that cognitive behavioural therapy can have on the mental health of teenagers. However, one of the limitations of cognitive treatments of depression is that there are individual differences. In other words, CBT may not be the most suitable for all patients. This can be seen in the results from the March et al. Study. It took 24 weeks for the improvement rate for CBT to almost match drug treatment, and 36 weeks to get up to around 80%. That's a long time. How many people are motivated enough and are able to stick with a program of treatment for that length of time? In fact, depressed patients may find the commitment and motivation required even more of a challenge. Therefore, it could be argued that whilst CBT is a treatment of depression can be effective, it may not be a treatment that can work for all. Furthermore, we can evaluate the cognitive treatment of depression by comparing it with alternate treatments. This can also be seen from the March et al. Study in 2007. Firstly, CBT contrasts favourably with drug treatment because it doesn't come with the negative side effects that often come with medication. Also, with medication comes the difficulty of getting the dosage level correct for the patient, which can take some time, and then the patient needs to be gradually weaned off the drug once they've improved. This can be quite challenging for the patient because they can experience withdrawal-like symptoms that can be quite unpleasant. CBT, on the other hand, doesn't have any of these difficulties. Secondly though, we saw from the March et al. Study that drug treatments for depression can work quicker than CBT and also doesn't have the demands of motivation and commitment that's needed for CBT, so biological treatments could be argued to be more effective in this regard. Finally, in terms of comparison, CBT can be argued to be more empowering for the patient in contrast to biological drug treatments. This is because patients taking antidepressant medication are passive in the process of drug medication taking effect on them, whereas CBT has the patient actively working to challenge and change their own thoughts. This is helpful because it can give the patient a sense of control over their depression, which they may not have had before. If you like this video and would like to see more, consider giving me some positive reinforcement with that like button and maybe leave a comment below. For more videos relating to psychopathology and mental disorders, check out this playlist. And if you would like more information relating to mental health, whether to help you or others, do check out the links in the description for some helpful online resources and support services. I hope you enjoyed the video. We'll see you in the next one.